Hey, good morning, everybody. Welcome to the latest Claremont Behaviour Change briefing event. My name's Ian Fannon. I'm Managing Director at Claremont. Today's event is focused on citizen-led commissioning in public health and how to engage communities early for more effective outcomes. And we're going to hear from some excellent speakers today who will talk about the value of co-design, co-production, and other forms of participatory research and engagement in improving the relevance, reach, and impact of public health services and interventions. And we're going to try and stay grounded and share examples of real-world applications of these approaches and hopefully help you take away really tangible insights and helpful tools to consider using in your organisations. I'm really pleased to say we're running today's webinar in partnership with the Behavioural Science and Public Health Network, and I'm pleased to have their CEO, Paul Chadwick, alongside me today. Welcome, Paul.
Thank you very much.
Paul is also Director of Behaviour is Everything. I'm going to ask Paul to say a few words shortly about why this issue matters to him. Before I introduce the other speakers, please can I ask our attendees to introduce themselves on the chat. Please tell us who you are and what you're interested in attending today's event for, and a bit about what you're hoping to get out of today. Also, please be aware we're recording today's session, and the recording will be made available afterwards on our website with the link emailed to all attendees. I'd also like to do a quick plug. I'm going to share my screen. I'm going to do a quick plug for a couple of our upcoming events. Bear with me a moment. So we have some great events coming up. Next week, we are going to be asking how we can create a society that values care, looking at transferable challenges and themes across both social care and childcare, and exploring what we can learn from recent framing and narrative development work that we've been doing in this space. And we're really pleased that we've got a stellar panel for that event, including our lovely clients, Rahati Chapman from Carers Trust, Sophie Fleming from Elevate Great, Sarah Ronan from the Early Education and Childcare Coalition, as well as Abhi Jitendra from Joseph Rowntree Foundation, Neil Crowther from Social Care Future, and Mary Nixon, who's a carer and disability activist. And then on the 23rd of October, we're doing our first little experimental event, a shorter event in a new bite-sized series, which is looking at the science behind scarcity. And my colleagues Philippa Williams and Cynthia Coe will be sharing a new report we've produced, which will reveal the extent to which scarcity of both money and time is an underappreciated and profound barrier to engaging with campaigns aimed at positive behaviour change, and what we can do to design better interventions that take the scarcity mindset into account. Okay, so that's the plug out the way. Let's get into today's webinar then and introduce our speakers. We have Sue Weaver. Say hi, Sue.
Hi there. Hi, everybody. Good morning.
Sue is Head of Commissioning for Public Health and Communities at Gloucestershire County Council, and is going to share learnings from Gloucestershire's approach to include local communities at the centre of their programmes and reflect on how co-production has helped shape more inclusive services. We've got Caroline Cook. Say hi, Caroline.
Hi, everyone. Good to meet
Caroline.
you.
Caroline's our is early diagnosis programme lead at North East London Cancer Alliance and a returning guest to our behaviour change briefing series. Caroline's going to talk about the Alliance's commitment to citizen-led approaches and share some examples of where this has been applied, including to help develop their health inequality strategy with Claremont's support this year. And then we have our own Dr. Tiago Mutella, who will reflect on what we've learned from our work in recent years using innovative and practical methods to move beyond sort of tick box consultation exercises and genuinely empower communities to play active roles in shaping and delivering health services and interventions. Say hi, Tiago.
Hi, everyone.
Okay. So please do ask our speakers questions as we go along using the Q&A function or the chat if you prefer. Each presentation will be around 10 minutes maximum. I think Tiago might go 1 or 2 minutes over that. So we can allow plenty of time for questions at the end and a good discussion, which Paul will also join alongside our speakers. We'll do our best to address as many questions as we can. We have got quite a large attendance today, so if we don't get a chance to ask your question in the discussion. We'll do our best to come back to you after the event. Yeah, and if there are questions that you want to pose at presenters as they've been speaking, then feel free to do that, and they may have respond to that, whilst the event is still going on directly on the Q&A function. Okay, so before we ask Sue to give her presentation, Paul, would you like to say a few words about the BSPHN and why this event and this topic matters to you?
Yeah, great, thank you. So I'm the CEO of the BSPHN, which is a bit of a mouthful as an acronym, but it stands for the Behavioural Science and Public Health Network, which probably should be the Behavioural Science and Public Sector Network. And we are a charity with a mission, like all charities have. And that mission is to make sure that the theories, methods and insights of behavioural science are embedded within all aspects of the design and delivery and evaluation of public sector services. Now, the reason we're behind this mission is because we believe, and there's plenty of evidence to support that belief, that a deep understanding of human behaviour will deliver more effective, efficient and equitable public services. And the reason we're here today, and the reason we're really excited about kind of this joint webinar, is that really citizen-led commissioning is at the heart of that mission. And there's a very simple truth as to why that is the case. And it can be expressed in the following sentence: people don't resist change, they resist being changed. And that simple truth applies to every single level of service provision, whether you're working with an individual, whether you're working with a community, or whether you're working with a population. If you impose change on people without consulting them, you dramatically increases the chance that they will resist that change. And that resistance may not be immediately apparent, but it actually may show up, and sometimes it is immediately apparent, but even more worryingly, that resistance may show up as some form, and potentially in a more serious form, down the line. And I think we're kind of seeing some of the some examples of that at the moment. So it's both kind of good and bad that I'm in my 4th decade now of changing behaviour as a kind of professional. I started as a kind of very young clinical psychologist. Looking back, I can honestly say that the history of service provision in the public sector, and kind of particularly public health, I think, is littered with the bones of really great interventions, some of which I've designed, some of which I haven't, that have probably not delivered on their promise, or they've not scaled effectively, or they've kind of led to inequalities. And this is the nature of the beast. But I think a big reason why that has happened is because those responsible for designing the interventions, commissioning the interventions, implementing it or delivering it, have not really done the very detailed, important and kind of sometimes arduous work of genuinely engaging with those people whose lives we're trying to change. So that's my pitch. This is why this topic is really, really important to us as a network. And I'm really looking forward to hearing about some great examples of deep listening.
Fantastic. Thanks, Paul. Yeah, I confess, I think I've been in this game quite a while too, yeah. And undoubtedly have got a graveyard of badly delivered programs that didn't involve people early enough. Didn't consider bringing the audience we were trying to engage into the process from the outset. And I can think of campaigns where we did that. I can think of interventions designed where we did that and still succeeded.
Yeah.
But I think it's a gamble. That's you're rolling the dice, aren't you? And our kind of perspective these days absolutely is that if you want to de-risk the approach and give yourself a better chance of it working, trying to engage the audience early is usually a good idea.
Absolutely.
Okay, so thank you. Real pleasure to be doing the event alongside you today, and glad you're with me. So I'm going to hand over then in a moment to our first presenter, Sue Weaver from Gloucestershire County Council. Before I do, really quick reminder, we're going to field the questions once we've heard all the presentations, so please do pop any questions into the Q&A function. Okay, so Sue, you've got your camera on already, and your mic on. Great, fantastic, and you're brilliant. Thank you. Okay, I'll leave it to you. I'm going to go off camera.
Thank you. I was just reflecting on my own graveyard then of 30 plus years of working in the public sector, and those interventions that were well-meaning but certainly didn't land with people. So yeah, thanks ever so much for inviting me to talk about this topic. So I lead in Gloucestershire on health improvement, which includes the healthy lifestyles portfolios, tobacco, weight management and so on. And I also do some system improvement work around health inequalities. And I'm currently on a mission also to secure investment into behavioural science expertise within the local council. If we go on to the next slide, I'm going to start with a massive disclaimer. I cannot profess to be an expert in behavioural science or in co-production, and we definitely haven't cracked it yet in Gloucestershire. But I'm lucky enough to work with some absolutely brilliant colleagues and partners who are really committed to doing things with people, not to them. And I'm going to share just a few of the things we're doing and a couple of case examples where we have really deeply consulted with and listened to people, and then what happened as a result. Next slide, please. So I prefer Paul's quote, actually. People don't resist change, they resist being changed. But here's another one. I mean, this is essentially all about listening instead of making assumptions. And besides the moral imperative to do things with people, not to them, there is, of course, a really, really strong business case for working in this way. I'm not going to detail all of the points on the slide because of time, but just to say that interventions that are built on first consulting with and really listening to and working with people, with individuals and communities, those people that the interventions are for are much more likely to be adopted by those people. Organisations are going to benefit from looking as though they're more attuned to their communities. And these interventions can absolutely be tailored to address very, very specific barriers to those people that we know are facing the greatest challenges in achieving health and health equity. It's also more fun and it's more creative, but there's a really strong business case for working in this way. If we go on to the next slide, this is quite a busy slide, so I'll try and explain what it's about. This is one of the ways we're trying to raise awareness of and embed citizen-led approaches and commissioning and planning in our local system. This is our Gloucestershire ICS Health Inequalities Framework, and all the key organisations and partnerships in Gloucestershire have signed up to this framework. And going back to the point I made and that Paul has made around the link between listening to our communities, adopting behavioural science approaches and helping to address inequalities, then there are some really strong links within this framework and working with individuals and communities. So on the left-hand side, we've got sort of ways of working, I suppose, that we're encouraging our local organisations and partnerships to start to embed as a matter of how they work, full stop. And that includes community engagement and co-production, taking a behavioural science approach. And then if we go right over to the right of the slide, underneath some of the ways in which we can improve our equity of access, experience and outcomes across our mainstream services, and really thinking about this when we're reviewing services or planning services, then delivering personalised care, delivering care around what matters to an individual, what their strengths and assets are, and what they need is, of course, another way of involving people very, very much in their care and their planning. So So all our organisations, as I say, and partnerships have signed up to this, and we're using a kind of self-assessment framework to and maturity matrix so that people can reflect on how they're doing, and then alongside that, running a community of practice, which we're just about to launch, so that we can share good practice among one another and challenges and learning. Next slide, please. So I'm going to go into a couple of examples, and this will be one that's well familiar to Paul, because he supported our local active partnership in Gloucestershire, Active Gloucestershire, with this particular example of behavioural science and very much community-led intervention. So on the back of lots of evidence that physical activity is preventive against falls among older people, the aim of this project was to try and increase the number of people who were doing strength and balance exercises, either by classes or at home. And we used Susan Mitchie's behaviour change wheel and combi model initially to map the system around older people. So who do they trust? Who do they listen to? Where do they go? Who influences their behaviour? And we then used the combi model, which many of you will be familiar with, to frame the questions that we asked older people and those people that work with them around the barriers and enablers to doing strength and balance exercises, either at home or by attending classes. If we go on to the next slide, our key findings listed on the right there, on the left there, rather. I'm not going to go into detail on those. You can read those for yourselves, but they gave us a really clear steer on what we needed to do in order to encourage and enable older to take up those strength and balance exercises. And some of the things that they led us to do were, firstly, some really clear what matters to me comms based on some of the motivations that older people told us about, largely around being independent and staying able. Secondly, we developed a bunch of training and also resources on how to do and how to maintain those activities at home. And those little cards you can see, the small cards you can see on the right, are really nice quality stand up on their own cards with taglines that link to the benefits of doing strength and balance exercises. So we had things like able like Mabel, I think we had stand like Stan, and in order to really help prompt that behaviour, because of course we've all got good intentions and then forget about what we're supposed to be doing, these little cards can be stood up by things like the kettle, the toaster, the phone, so that you'll have habit stacking, and when people are waiting for the kettle to boil, there's a prompt there to do some of those strength and balance exercises in the home. And the last thing that we did was to train and identify over 200 older people's champions within communities on the back of the fact that these things weren't really being talked about, to spread the word. So next slide, please. There was an evaluation of the project. We didn't attempt to demonstrate that as a result of this project, there was a reduction in falls-related admissions to hospital. What we used are some proxy measures, which included awareness of risks, awareness of the benefits of strength and balance, and most importantly of all, whether or not there was an actual change in terms of people doing strength and balance exercises at home. And you can see the results there were quite significant in terms of both the awareness and the change behaviour. I'm going to go on to my second case study now with the next slide. And this is a weight management example. I've worked in weight management, I think, since the very late 80s. And there's a real graveyard of interventions linked to weight management, various things that have been put on within communities and haven't managed to engage people, particularly not those things that have been aimed at families. So we were lucky enough, going back to about 2018-19, to secure 3 years of funding, and the agreement from funders, really importantly, the agreement from funders that we didn't need to do any delivery for the first 9 months. And we used those 9 months to gather insights, within communities, and also to map assets within those communities, so that we could base our interventions on real understanding of some of the barriers and some of the real life situations that families were facing, and why they perhaps didn't turn up to our previous well-meaning weight management interventions. So if we go on to the next slide. We've got a few themes here, the key themes that came out of the focus groups and the one-to-one sessions that we ran with families and with people who work with families who have children. You can see the themes for yourselves. They range from real structural things around environment, around finances, around health. They also include feelings, so tiredness, mood, etc., circumstances, social support, and a range of other things. On the back of those themes, which were analysed using and groups using the CONBI and behaviour change wheel, then we developed a kind of hyper-local approach to delivering weight management. I should have said before that the things that came out of the insights were really quite different between urban and rural communities, but also even within Gloucester City, where we ran a number of these insight exercises, then there were quite different themes within different communities that might have only been 2 or 3 miles apart geographically. So in response then to the findings, we ran programmes in which the timing, the format of the programmes, the delivery method, and the content were very much informed by those families that we developed the relationships with. We also developed what we called a structural resilience model, and I'm going to go on to the next slide and explain that. Formally, we would look at assessing an individual or family's readiness to change, perhaps using the Diclementi progression model that I think came out in the late 80s around readiness to change and the cycle of change, and to look at this alone. Following the engagement that we did with families, we realised that actually it was much broader than that, and many families just simply were not in a place to be able to engage with any form of behaviour change, and that it was quite inappropriate and unfair to expect them to engage when they've got so many things going on in their lives. So the structural resilience model sort of triage families based on a really holistic initial assessment, according to their circumstances, their social, emotional, financial, structural, how stable things were for them at the time. And those green families who were ready to go, they would be, and presenting really with low complexity, they would be able to access behavioural change weight management support straight away. The yellow families received advice and support to build a little bit more of a stable base on which to base their future behaviour change efforts, so they could really build in some habit changes. And then those red families facing more complex challenges, it really felt very unethical and impractical to try and engage them in behaviour change support at that time. So the service really kept in contact with those families, just so that at the point at which, and very much signposted them to support, so that at a point at which they may then be able to engage in future, they would be able to be sort of scooped up and supported into a behaviour change and a weight management programme. That model is still being implemented today, although we don't, I think, probably call it the structural resilience model. It's based around a single point of access to weight management support in Gloucestershire, and a really good holistic assessment at the beginning. Go on to my final slide, if you might, please. So finally, I said at the beginning, we're a work in progress. So we're gradually moving towards, I think, more personal and community-centred ways of working. Just a few of my takeaways, and some of the things that we've found that we need to really be mindful of. Firstly, managing expectations, and selling that point that we need to really take a step back and take some time in order to be able to go faster and more effectively later, and to get better outcomes. And I go so far to saying, and I think this builds on Paul's point, if we're not making our interventions and our reviews of services and our quality improvement person-led, then it's not really worth doing them. I think one of my other points is we're going to efforts in Gloucestershire to pool and share some of our insights. So our Integrated Care Board have developed a central hub for insight data, so that we make sure we're using what we've got. We're not going back and asking communities, the same communities, similar questions the year later, and having not acted on the ones that they've told us before. I've put a little link on the slide. It's called Join the Up Insights in Gloucestershire, and that's on the NHS Futures platform, and anyone's welcome to go in and have a look at that. I think the other key thing around that is do act on the feedback you get. Some young people told us recently, don't waste our time, listen to us and respect what we're saying. And also in terms of acting on what communities are telling us, go back and tell them what you have done, so that they actually do, so that we're building that trust in those relationships that are crucial to be able to work in this way going forward. And then finally, we're currently building a business case for some substantive investment in behavioural science expertise. We're finding examples that demonstrate return on investment, either in cash terms or impact on local authority priorities, have been quite hard to gather. So please, if you're working this way, as many people are, I'm sure many people on this call have got lots of examples for themselves, then please do write them up and share them, so that we can all use that evidence going forward to do more of this work. And that's my spiel. Thank you very much, everyone, for listening. I hope I haven't gone too far over my 10 minutes.
No, we're okay. We're all right. I think okay. We're about 2 minutes behind, but we can catch that up. We're all good. I really enjoyed that presentation. I think multiple things I've jotted down that I fully endorse. I think the stuff you were talking about at the start about the business case for this approach, and the need to take a strength-based approach to kind of building health and well-being in your communities. I really love the way you assess the readiness to change and tailoring those journeys according to that. That's really nice work. Can't agree enough with your point about acting on feedback and then returning to people. I think there's a lot of examples of attempts at co-production or co-design that are extractive. Where you go and you extract insight or input from people, and then they never hear from you again. And if you want to continually work with your communities, particularly if you're in a localized area, then being able to go back to people and act on their feedback, but also let them know how their input has shaped things. I think it's really buy-in, doesn't it?
It does, and it's thinking about these relationships in the longer term rather than as a quick drop in. Build a relationship, we're being nice at the moment because we want something, and it's really thinking about those relationships in the longer term. That certainly came out during the pandemic, and the efforts that colleagues had made to build relationships substantively within communities really came to the fore, because we knew where to go. We knew who we could tap into, who we could talk to around, for example, the vaccinations and equality around that and so on. So it's very much thinking about that as rather than as discrete projects, but as a continuum of engaging with communities.
Okay. I think that theme might well be something that Caroline touches on as well. So thank you, Sue. If you can go off camera and off mic again now. And I'm going to invite Caroline Cook from East London Cancer Alliance to share your screen and give your presentation. Over to you, Caroline.
Thank you. I'm going to attempt to share my. So as Sue said, I'm also not an expert in co-production. I've only been doing this for maybe the last sort of 3-4 years, really, probably 3 years properly. So I'm not an expert in this, and as I said, I'm quite new to it. but it is something that I have learned very quickly is incredibly important. So I'm just going to talk a little bit about a couple of the projects that we've worked on in North East London, just a couple of campaigns that we've designed and co-produced with the population. So if you go to the next slide, please. So first, I just said, why co-produce? Well, in North East London, we have a very, very diverse population, probably some of the most deprived areas in the country, huge disparities in health outcomes. So we have a very different population in Tower Hamlets than we have in Havering, where we have a larger white, sort of not well off population, but they're probably more well off than those that are living in inner London. So, for example, we have a very large Bangladeshi population in Tower Hamlets and Newham. We also have one of the most deprived boroughs, or I think the most deprived borough in London, in Barking and Dagenham, and lots of child poverty in that kind of area. So we've got a really diverse group of people that we're trying to reach with some of our cancer projects. And it's just, I think, one of the most important things that we've found, I think, as Sue and Paul have alluded to, you can't make people change by imposing something on them. You have to understand what it is that is going to change that behaviour. What are the triggers for them? So what we've learned with our population is one size definitely doesn't fit all. We need to adapt, and the only way we can do that is by actually engaging with the population. And again, Sue did spoke about some of the things that I was also going to stress, and that's that feedback loop. So it's all very well speaking to people, but you need to, it's an iterative process, I think, and you need to make sure you're feeding back and you're keeping in touch with people. We've been working with the Gypsy Roma traveller population, and they were very, very clear at the front. They don't want to work with us if we're just going to take some information and go away again. They want something sustainable, and then that's the way to build those relationships, and you just can really do some positive work there. So I think the other thing that Sue did allude to as well was that we can make assumptions, but we don't really know. We think we know sometimes what people need and what's going to help people, what's going to engage people, but we don't. And we can make assumptions and then get it horribly wrong. And only the communities that we work with or that we're trying to serve will know what the barriers are. In our case, the barriers to accessing screening services or going to see their GP with a sign or a symptom of cancer. The only people that know that are the people that we're trying to reach, really, and their wider communities, so maybe faith groups and community leaders. And there's some, it can be some very sort of nuanced things. So things that we found, for example, if you're talking about language, what kind of language should we be using? What is acceptable? What's taboo? What words don't translate well into other languages? And sometimes we just don't know these things. We don't know what the message is. We need to understand who they trust to give them that message as well, and what's the best way to do it and where. So if we just move on, I'll just talk through a couple of things. So this was the first campaign that we did any co-production on. We had done some work before and not so successfully. So this was a project for the LGBTQ plus population, mostly lesbian women who weren't attending their breast screening appointments for lots of reasons. So we obviously pulled a group together, quite a large group of people from the community in North East London, and got to work sort of thinking about what is it that that stops them from going, and that was the starting point. So we ended up with a design. So there were many iterations of this design. It's very much led by the people that are in it. So there were 4 different pictures altogether. So one of the things that came out, for example, and some things that we just didn't think of, and it was when we first designed this, or it wasn't us, it was an agency, the white box that's surrounding was just going around the whole of the picture. So that person in the photograph was included, was inside the box, And one of the first things they said was, you're putting us in a box. And I thought, we hadn't even thought of that. So can you put us outside of the box? So, and it seemed like something very, very little, but actually it was really important to them. But what was the most important was to be seen to see people that they could recognize as being themselves and like themselves. So basically it took nearly a year to design this, because we went through so many iterations, many focus groups, many sort of like groups coming together, and we worked very closely with Live Through This, who are now called Outpatients, who are a charity, the only charity that I'm aware of that works with LGBTQ plus people that have got cancer or have had cancer. So we worked very closely with them as well, and they've continued this to use this campaign on their own website. So what was really important as well, I've just put a couple of quotes on there from Ramesses, who was a trans man who was still hadn't gone for breast screening, because though he still hadn't had top surgery, but mainly because of he was worried about the people sort of being quite denigrating to him, and so he didn't want to go. He was afraid to go, but it was for us, it was a testament that he said, I felt really part of this. I felt that we've been listened to, we've been heard, and we're represented, and that's so important, because if we see this, then we're more likely to want to go and do it. We're looking at people that we recognise. So if you move on to the next slide. So the next slide. So this was the next project. From what we'd learned before, we thought it was really important, again, to have real people in the campaign, but we'd also did the same thing. So first of all, we were working on womb cancer, and we worked with, so the lady on the left, my left anyway, is Pfizer, and she was one of 3 women we included in the campaign to raise awareness of womb cancer, and they'd all been so involved. We'd got a very diverse group of women over the age of 50, sort of menopausal women, to come in, and what we did is we worked with the Eve appeal, because what they wanted to hear about it. They didn't just want to see something, they wanted to hear about it as well. They wanted people to talk to them. So we set up some sessions as well with women's groups, and also there were some men at these groups who said that we really need to know this information. But what was important was that we had real people, so they could recognize themselves, and that's what they wanted to see. They didn't want to see this on bus stops either. They didn't want to see it on billboards. They wanted the message to get to them through other women, and by talking mainly, or by community groups, but on a much more hyper local thing. So maybe in hairdressers, nail salons, the places that women will go to. And then from that, we then kind of continued to adapt the same theme of the campaign into ovarian cancer, and that's a very different population group. So the lady on the right was in the focus groups and the co-production workshops that we held for that, and we came up with slightly different sort of wording and everything, but it was a similar idea. And then where did they want the message to come from? And they needed to hear it. They needed to see themselves again. They wanted the same thing, in that they wanted women's groups. They wanted places where women will be, so they could have those open conversations and talk about things. And that is really what so we designed the campaign, but also the outreach sessions, to really sort of fit with what women wanted, what was going to help them to talk about their experiences, to talk about their fears, talk about the different signs and symptoms, and also it to sort of like make them feel empowered to be able to go away and talk to other people, which is really important for the work that we do. It's not just about what we're telling people, it's about how we can help people to spread that message. So, and I think my last slide is just a very big picture. It's like, where do we want to be now? So what's happened is, as I said, we've got a very diverse population, and many different communities. In one borough alone, we've got nearly 200 different dialects that are spoken. So it can make things quite not difficult. It's not difficult. They're not hard to reach. These people aren't hard to reach. We're just not very good at reaching people sometimes. So we have asked Claremont to help us to develop a health inequality strategy for cancer. And the idea is this will be system wide. So it's not just for us in the Cancer Alliance, it's for primary care, secondary care, public health, everyone that works in cancer services across North East London. And I know that Tiago is going to talk about the amazing work that he's already started for us. And I'm sure he can explain it a lot better than I will be able to. Thank you.
Thanks, Caroline. Thank you. Really appreciate that. I think I've jotted down a number of things that really resonated with me. I think the use of real people. We try and do that in our campaigns wherever possible. I think the authenticity that comes through when you do that to address that need that you described for people to see people like themselves in those campaigns, and for it to feel real. I love the best for my chest example and that small insight around don't put us in a box. It's such a great example of one of the things you learn when you do co-design properly with people. So thank you, really appreciate your presentation. We're a little behind, but I think Tiago can hopefully help catch us up. So if you go off camera now, Caroline, and Tiago, can you come back? Yeah, there we go. I'll leave it over to you.
I like the wishful thinking about me being on time, so appreciate that. So first of all, thanks for the opportunity to present. When I was thinking about this presentation, so I had lots of conversations about this, and when I was thinking about these slides, I kept coming back to the idea of what does it really mean to truly involve community in shaping public health thinking and public health services. So there's a lot of buzzwords in public health. There's things being done for people, not with people. Public health is very prone to those sort of buzzwords, sort of conversations. Communities are sometimes engaged based on a tick box exercise rather than a process. Services, we've seen lots of services being technically sound, really good from the behavior change element, but not fully aligned with what people care about. So for this presentation, I want to give you some examples of what true community engagement means to us, to me, and how that can help shape public health services. So true community engagement, it means treating community as an ongoing process. So engagement is an ongoing process rather than just a tick box. And a good example of that is the work that we've done with the Gloucestershire County Council, their public health team. So the ask was to engage with groups with higher prevalence of smoking, so substance misuse, people with substance misuse challenges, Polish communities, LGBT communities, and people living in supported accommodation, and ultimately to inform the development of their new service. So they were about to commission a new service. They want to understand what direction should that go, what things did the service need to have, and what kind of were the key elements that were essential to the service in order to engage people. So at the heart of this project, and our approach was to place community expertise and community practices at the centre. So we started by focusing on what works well rather than just what needs improvement. So this is something that I've seen a lot everywhere, is almost like an obsession of trying to fix what's broken rather than starting by understanding what works. So what we've done was an extensive piece of work, speaking to colleagues from public health across the country to understand the services that were being delivered in their areas, what was working, what were people engaging with, understanding the key ingredients that were enabling people to change their behaviors and to engage with the service, to kind of set the scene for the direction of the project. We still looked into the things that need improvement and the groups that needed more focus, but a key element was to just focus on what was working well elsewhere. We then did a huge piece of on-the-ground engagement. So we've partnered with community ambassadors, community leaders, people with recognizable faces in Gloucestershire, people worked and lived in Gloucestershire, to go and speak to other people about their behaviors. And the key point was to just be human and connect with them on a human level. We went to speak outside waiting rooms, shops, pubs, school gates. We connected with mums that were having conversations with other mums about these things. We connected with shop owners, and the idea was to add an informal element to this, not just go in with all the behavior science element, with all the system thinking, but just be human and connecting with people on a human level, and try to understand what's it like to live in Gloucestershire and smoke in Gloucestershire, and trying to stop smoking. What's it like to navigate the landscape? What's it like to try and seek help and seek support? So we place the emphasis on an informal approach blended with some behaviorally informed strategies. What we've then done after building this body of knowledge and after bringing people together on the journey with us, it was we co-developed an approach with community organizations to run more structured sessions. So the whole session was co-created, co-produced with them, even in terms of the location of the session, the structure, the format, the sort of topic guides and the interview schedule. That was all co-defined and co-designed with the community organizations. And what we wanted was, as we're walking towards creating an idea for what the service could look like, we wanted to make sure that we're going on the right track, that we're truly representing the things that people were telling us. So in these sessions, what we've run was we shared specific mock-ups of what the service could look like, specific ideas, elements in terms of should it be a face-to-face and online. We dissected really a service even before the service were commissioned to really understand what people cared about. And what we've done in the end was we've gathered qualitative data to validate those findings. Going back to what has been said, we went back to people to make sure that we were on the right track. We're truly representing the things they told us, the things they cared about. And we tested some ideas that could be implemented into service in terms of formats, locations, the messaging, the framing, and all that sort of thing. So what that meant to us was not only did we manage to work with people to think about recommendations for engagement, for service delivery, for content and for messaging, but because of this approach, what we've done is we've developed a people-centered model to guide commissioning and developing of smoking services. So throughout the process, using behavior change expertise and the lived experience of local people, we've developed a matrix to help service providers, commissioners, and campaigns not to predict per se, but to estimate and anticipate the levels of engagement that the service will have. And what that means in practice is, if you have these key ingredients, if you apply these elements, if you do these things, if these things are present, people will be more likely to engage with your service. People will be more likely to come to you. And what is happening at the moment is that this matrix, this concept, is being used to develop the tender evaluation and to shape the service itself, which I think is a very good example of how engaging with people early before the service is in place is absolutely essential, because it gives you a much better understanding of how to engage, what people need, what people want, and has direct input from people. The other point is that true community engagement means creating with people, not for people. And a good example of that, and Caroline already mentioned this, is we've been working with the North East London Cancer Alliance for several years on different campaigns and different co-production process. But I want to tell you about the latest work we've been doing with them. So the ask was, like Caroline mentioned, to create a health and equality strategy for the whole of North East London when it comes to cancer. Though we're talking about a huge piece of work in terms of the system level, involves a lot of partners, different public health teams, primary sector, etc., etc. So, but we wanted to do this a bit differently. So rather than just focusing on what the system want, we wanted to bring local residents, people who experience health inequalities, people who know what it's like to struggle to get access to services, into the room, into the decision-making room. So we've used an approach called Citizens Panel. I'm not sure if people know what that is, but it all comes down to collective decision making. So it's a number of sessions where people are informed about the things that we're trying to achieve. There's opportunity to debate, to deliberate, to exchange ideas and to challenge ideas, and we all come together towards prioritization of what that strategy could look like. And the way we've approached this was we've done a huge piece of recruitment and community engagement with 30 people from North East London. There was a strong focus on the most deprived 20%. So we've recruited a lot of people from the quintile 1 and 2 of the deprivation index, brought them into the process, into the room to have these conversations with us. There was a different mix of gender, ethnicity, location, age, that sort of thing. And more importantly, there were different levels of engagement with the system. So there were people that bought into the idea of going for screening or seeking help through a service. There are people completely against it. We had lots of people who engaged in this process. They said, I don't respond to letters, to the NHS letters. I don't engage with my GP. I don't trust the system. So we wanted a blend of ideas, a diversity of thinking into the room so we could all come together to create this strategy. We've delivered this across 4 sessions. So it was a very intense month with 3 online sessions and 1 in-person session. And everything led to a prioritization of what health inequality strategy should look like. So throughout the sessions, people had opportunity to debate, to ask questions to experts, to challenge Caroline, to challenge her team and say, why is this not happening? Why are you doing this instead of that? So again, bringing them into the room, into the decision-making room. And ultimately, there needed to be trade-offs. So the final day was all about prioritization. It was all about saying that there were a lot of ideas, there were a lot of important issues, a lot of urgent issues, but we need trade-offs. We need to prioritize this. In order to move forward, things need to be actioned now, others need to be parked. So the final exercise, again, represented true joint decision-making of bringing people into the room. So what we end up getting was a prioritization of themes of things that will go into the health inequality strategy, a clear action plan, which was a blend between lived experience, local communities, and the system. One final point, because I can sense Ian is probably checking his watch, is truly engaging with local communities sometimes means flipping the script and innovating. And the final example I've got to tell you about is the work we've been doing with the Barking and Dagenham public health team around vaccine hesitancy. Very interestingly, Paul mentioned imposing change, and people don't want to resist change. They resist being changed. And that was at the heart of this particular project. So those huge rates of vaccine hesitancy, particularly in Romanian Black African communities in Barking and Dagenham. There's a lot of great campaigns. We've worked on several campaigns in the past with good degrees of positive results, but we wanted to do things a bit differently because we wanted to scale. So what we did was we went back to local communities and asked them to work with us in order to progress this and to work towards change. The way we've done this was to create a safe environment, a relatable environment, an environment of empathy that people could talk to. So we didn't go in imposing change. We didn't want to pressure people to get vaccinated or to go and speak to healthcare professionals about that. At this stage in this pilot, we just wanted to engage with people to have a conversation, to just acknowledge their concerns as valid. And what we found, one very interestingly, we managed to speak to a lot of people who rejected completely the idea of getting vaccinated. And even the fact that we managed to get them in a room and to speak to us was absolutely fantastic. But what we found was there was a lot of concerns about vaccine. People rejected it because they were unsure. They wanted to protect their children, and they were doing it by not getting people vaccinated. And what we found was it's much more easier for them to speak to local leaders, to community ambassadors, to people they relate to people they know, than to healthcare professionals. So what we're working towards, and there's commitment to continue working towards this, is to equip local leaders with the capacity, with the tools to have these conversations, to talk about vaccines, to reduce people's concerns, to challenge some views, and ultimately to offer them the support they need, not by telling them what they need to do, but by offering the support that they need. And one final slide before I finish. If you want to remember 3 things from these slides is please share knowledge and go beyond the buzzwords. Combine the hundreds of reports that you have in your desks and the needs assessments. They'll tell you everything that people need and want with joint decision making. Bring people in the room. Don't just make the decisions on your own. Bring people into the room. Build capacity, plan, create and deliver service and programs with people, not for them. Bring people early on. Don't just do a tick box exercise at the end after everything has been decided. Just go and speak to people to say, oh, is that good? Bring them early on, build capacity, and then be creative and brave. There's a lot of system changes that need to happen. These are complicated conversations about unlocking programs of work, unlocking fundings. Just be brave. Patching problems won't fix the solutions, and part of this is having those conversations, is speaking and being brave and being bold to bring these creative elements forward. Thank you.
Thank you, Tiago. So, excuse me. Thank you, Tiago. I liked seeing lots of sort of thumbs up and hearts there on that final point about bravery, which I wholeheartedly agree with. Okay, so we're going to go to questions. If all of our panel can come back on camera, please. And I'm going to do my best. We've got a lot of questions coming in, so I'm going to do my best to try and prioritize some of the questions that people have been upvoting. So if you see a question in there that you think is particularly important, do give it a little thumbs up, and we'll try and get to that earlier. So I'm going to start with a question from Verity Harrison to Sue. To what extent were you constrained in your ability to implement co-produced models due to national guidance or regional requirements to standardise interventions?
That's such a great question, isn't it? In a way, for me, it feels even more important to co-produce models when a very kind of one-size-fits-all diktat is being proposed, and I suppose we're balancing things, aren't we? We're balancing expectations, funders' expectations, and so on, and the evidence base as to what works, which is quite often quite rigid, isn't it, and based on trial data and so on. I'm thinking weight management, and we know that that's about interventions around healthy eating, physical activity, and behaviour change, with what's going to actually engage people and encourage people to attend, and what other things might matter to people in terms of enabling them to engage with that intervention, whatever that is. So I suppose I hope I'm answering the question. I suppose it's around staying true to some of the criteria that are givens, but really working with individuals, communities, potentially different cohorts of people within your community, to understand, well, how can we make this work for you? What would enable you to engage with this? So I think it's kind of almost bringing the preset criteria together with that knowledge of what will enable real people to engage with that intervention. And I'd probably go so far as to sometimes, depending on, and this comes back to being brave and being creative, I guess, doesn't it? But I'd probably go so far in some instances to say, well, actually, we're going to try something that kind of is aiming for the same thing, but we're going to deliver it in a different way. And just to give an example, I think many people on the call that are linked in with weight management programs and interventions will know that we're tending to move away from strictly tiered weight management models of care now, because they don't work for individuals. They put people into Caroline's boxes, and so we're moving, despite the fact that the sort of the official line is around tiers, we're moving very much towards much more kind of person-centred, flexible approaches to delivering, yes, some of those same evidence-based interventions, but we're looking at much more of a kind of matching the individual or the community to the intervention approach through what communities and individuals are telling us will work for them. I'm not sure if I've answered your question properly.
That's great, thank you.
Breaking the rules sometimes, I guess, a little bit in to the extent that you potentially can.
Yeah, I mean, Paul, I'm interested in your take on this, and whether you've seen that barrier play out with people you've worked with, but also broaden it. What are some of the other common barriers that you see to meaningful community engagement in the work you've been doing?
Yeah, thank you. I think a big theme that's come out from the presentations that definitely echoes with what I would think is trust, and I think there's actually probably two sorts of trust that we need to kind of think about. We kind of need to trust our communities to I think we need to trust our communities that they know what is right. They will have an opinion, but I think sometimes we kind of engage in kind of tick box exercises that don't really challenge the communities to tell us what they really think about things. And I think it's like an onion. when I'm working with anybody or any community of change, there's this kind of change onion, and you've got to have time to kind of peel back the different things, because people will tell you what they want you to hear.
Well, they think you want to hear.
And they think, and then you have to represent it back to them, and it's like, oh well, actually no, it's about this. And so it's this continual peeling of the onion. And so I think another major barrier, which I think Sue's presentation illustrated quite nicely, is commissioners giving services time to peel the onion, to cry a little bit when we find out what's going on and think, oh my God, and then to refresh our ideas. And I think sometimes the other kind of barrier is that I think we need bridges between professional understandings and personal understandings. And I think we talk a lot about PPI, definitely in the research world, so patient professional involvement. I think we need to think a bit more creatively about that as well. I think I think there's a hidden resource. I think as long as we see ourselves as professionals as being separate from the communities that we work with, we're going to really struggle to understand people and talk genuinely with people. I think there's a great resource in public health, particularly of professionals with personal experience of the issues that we're trying to solve, but we're never allowed to kind of talk about that. So what would happen if we gave our professionals permission to talk about their experience things in a genuine way? And often, we're growing these professionals who come from the communities that we're trying to reach, and then we're putting this barrier. It's like a damp-proof course between where they've come from and who they are as professionals. What happened if we removed that damp-proof course, talked about this seriously, and I think that would give us greater, I'm going to use a terrible word here, but penetration into the people we're trying to meet. Because I come from a very working class background. I know what's going on. I know the real belief systems that's behind many of these resistances. But you're not really allowed to kind of bring that into the work. So I'd like us to be brave in a different way. And to get more meaningful engagement. And if we don't do that, I think a lot of us have experiences where we're doing stuff that we don't necessarily genuinely believe in. I think we need to kind of remove that barrier a little bit and then allow more meaningful engagement.
Yeah, I think we can put different hats on.
Yes, we definitely can.
And allow ourselves to adopt different stances. There are moments where you need to be super objective, don't you, and step back. But there are other moments you can dial in and share some of yourself. I think I'm super interested in the unlocked resources as well around professionals and people with lived experience actually sitting in rooms together.
Yeah.
I think there's a lot of resistance to that. We often go and speak to those groups separately.
Yeah.
And there are some challenges bringing people together. The power dynamics, how you ensure that you genuinely give equal weight to the input of those with lived experience to those who are bringing a professional perspective. But it can be done, and it can be done well. And I think that there's real risks at the moment that we treat these as separate exercises, that this expertise exists in different pots.
Can I just add, Ian? Can I just add to that? Because I think you've touched on a very important point. I think one of the risks of co-production is that we're putting the burden on people to fix systemic problems, and I think that is not possible. We can't go to people to ask them to fix the problem with the system, and I think that just speaks volumes to what you were saying in terms of it is important to bring professionals, but it's also important to bring the wider system, to get people to understand the system, to speak to providers, to challenge providers, to challenge the system. Otherwise, if we're just focusing on that co-production element of yes, this is the problem, but go and fix it, it's just not fair.
Okay.
Can I respond to that?
Go for it. And then I'm going to get some questions.
But I think sometimes we should do more to kind of bring our communities into our world. and understand the challenges that are involved in having a limited pot of money and this massive remit, and bring them into kind of our world rather than just us trying to enter their world. I think there needs to be genuine.
That was the objective with the citizens panel work that we did with Caroline. You know, the first 2 sessions of 4 sessions really were about us giving evidence and information to that group to bring up their knowledge base. So they brought their lived experience, but we gave them additional information that then equalised the room. You know, so that you then can build from there. And we dedicated loads of time then to deliberating on that to get to the final outcome. Okay, I must get to some questions. We've got one for Caroline from Jill Nicholson. It's interesting that men were mentioned as a secondary target group for the work on womb cancer, but they self-identified themselves as an audience who needed to know this information. What's been learnt from this, and what was the impact of including them?
So they weren't even identified by us. They identified themselves, as you said. So what happened is we went to do a talk at we thought a women's group, and there were a few men there. And at the end of it, they said to us, you know, we need to know this. We need to know about the health of our wives, our sisters, our daughters. So we need to understand this. So what we have done, we've taken that away and worked it into new projects. It's just us making an assumption, I think, that only women needed to know this. So it's been a learning experience for us. And it's not, it's the, what I think sometimes in the advertising agencies call the nagging network. So it's the loved ones that are the ones that often push people forward. So I think it's made us think a bit wider. And the impact of that is how we have then moved on as we progress with each project, how we sort of widen our scope a bit and think and ask, but who is it that needs to know? It's not just that very sort of like targeted group of people. And I think the citizens panel was really pulling that out. It's just sort of like that, who we should be involving in the work that we do. It's quite so I think that's probably been a learning curve for us. And I think as we move on from project to project, we're thinking a bit more about our scope and who we should really be speaking with.
Okay, thank you.
Does that answer the question?
Yes, it does. Thank you. That's really helpful.
Okay.
I'm going to come back to you again, Sue. So Johanna Jeffries has asked, what were the criteria that were used to assign families to each of the 4 groups, and did the families assign themselves?
It's a great question as well, isn't it? And yeah, it does sound a bit like putting people in boxes, doesn't it? When we call people, a green family, or a yellow family, or a red family. So sort of loosely speaking, we were thinking about the parameters within COMBI. So we know that in order to be able to engage with behaviour change, people need to have the motivation, they need to have the opportunity, and they need to have the capability to engage in that change. But of course, we're not talking COMBI with individual families when we're trying to work out with them what might be right for them at the moment. So at the back of our minds, we're thinking of those some of those barriers and some of the enablers that the families told us about during the insights research. So things like we've got a lot going on, we've got this going on. In fact, when we did the insight research originally, if you remember the way that welfare benefits were being paid changed in around 2019, and we were talking to lots of families who were actually really stuck. They were fine for the first 2 weeks of the month, but come the 3rd week they were really strapped for cash, which was a massive barrier to being able to engage in a weight management or a healthy lifestyles kind of intervention. So the sorts of questions that we would be asking people would be much more open and generic than what your financial circumstances like, but would be things like what matters to you right now, where are you at in terms of what sorts of things might enable you to engage with this programme, based on some understanding of what the requirements and what the programme would involve? What are some of the sorts of things that might get in the way of you being able to engage with that right now? What are some of the things that might need to be in place for you to be able to engage with that? And at the back of your mind, you're thinking about some of those structural things, some of the psychological things. What's going on for you at the moment? Who might support you with this? And you're asking those sorts of questions to elicit and to come really to a collective view with that family as to whether or not they're ready now to jump in and do this, whether or not there are a couple of things that we might support them to put into place in order for them to become more ready to be able to engage with and benefit from this programme. And if they've really got a lot going on, and some of the questions were almost around kind of stability at the time. We know if we've got big change going on within our lives at a particular time, you know, we're moving house or we're in the middle of X, Y, or Z, we're much less likely to be able to build healthy habits on top of that chaos that's going on. So the sorts of questions we're asking, rather than ticking boxes and say, you know, against a set of criteria, the sorts of conversations we're having with families would be really to understand sort of where they're at generally, what some of the barriers might be, what some of the enablers might be, how stable things are at the moment. And we were talking with lots and lots of families with quite a lot of complexity going on. So there might be child protection plans, there might be real financial difficulties, housing difficulties, and so on. And in the meantime, for those families that felt as though actually now isn't a good time, there would then be a lot of signposting and supporting those families to access the type of support that they might need in order to be able to put some of those things in place that would enable them then to engage with the programme. So they might then be contacted later on down the line to see how they're doing, and then to invite them into the intervention then. But it would be very much a collaborative decision with the family. We're not going, if somebody is absolutely keen to engage now, then and despite things that are going on, then of course we're not going to turn a family away. I hope that answers.
Yeah, that's fantastic. Thank you. I mean, it's interestingly, a lot what you're describing is very relevant to the event I plugged at the start of the webinar about the science behind scarcity. We're going to be publishing a report that's going to kind of dive into this and some of the behavioural theory and evidence behind this issue, because you're right, like when people are living in extreme scarcity of time and or money or both, their headspace to be able to engage with change is severely hampered.
We don't want people to have a failure, we don't want people to have a failure under their belts.
That's right.
And
I think on the flip side, I think there's something really interesting that we sometimes look at about moments of contextual disruption in people's lives actually being optimum times for change. There's got to be a readiness, there's got to be a degree of stability, but often, you're right, maybe not in the throes of moving house, but maybe soon after moving house, there's a shift that happens in people's lives that then potentially enables them to reconsider some of their habits. So that's something to consider too. Okay. Let's get back to the questions now. A really interesting question from Leslie Lewis about incentives, which is a regular topic of discussion at Claremont. So I'm going to start with Tiago. Did we provide any incentives for engagement? And if so, what were they? And if not, how did you sell it?
Yes, absolutely. I could talk about that for ages. Yes, you need to pay people for their time, for their contributions, for the way they are allowing you to progress the project, the way they're allowing you to progress the system. In terms of incentives, for the citizens panel, our approach was to connect with organizations who support people and try to co-decide that with them. We've got a set incentive that we pay. We also offered iPads and tablets and things if people wanted to join, because some of the sessions were online. So in case of digital inequalities, there was also an option. So the key idea was to pay people for their time and for their contributions, and to make sure they could participate in a way that worked for them. So even in terms of traveling, the final session was online. We covered traveling expenses. On the day, it was a full day event. There was food, there was drinks, there was all that sort of thing. I think that this all boils down to what Paul mentioned in terms of almost like a discrepancy between professionals and participants in this case. And when we deliver these sort of projects, when we deliver co-production, we're working with people, and therefore they need to be compensated for that.
I actually have started not using the word incentive because it implies that you're manipulating them people to get involved, when really you're compensating, as you said, or reimbursing them for their time. You're recognizing that they're bringing value, and that contribution needs to be paid for.
Yeah.
Does anyone else have a comment on that before we move on to other questions? There's a queue of them.
I was just going to say, I think it's just actually showing how much you value someone's time and their contribution, and why shouldn't you be paid for or compensated, as you said, for that input. So I totally, and I was actually on the last day of when we had the in-person citizens panel. I remember talking to people and saying, I'm really surprised everybody has turned up. Everybody that's been on every meeting has come in person on a Saturday afternoon or morning to afternoon to participate.
6 hours as well, wasn't it? It was a long session.
It was, but there was the view was actually this is really important work, so it's important to everybody that's here. So I kind of got the impression they might have done it. Some of them might have done it even without that compensation, but I think it probably just sort of, it's just making people feel that what they're saying is valued.
Yeah. On a slightly sort of different tack, I don't think this would be an incentive. We have kind of thrown a bit of a party with as a means of engaging. So while there hasn't been an incentive in terms of a payment or what have you, when we wanted to engage with the community, we've thrown a kind of family event, which included food, which included entertainment for the kids, etc., 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 and use that event and being clear and open about the fact that we were going to use that event to sit down with some of the families while we're there and just have conversations about what was working for them within their community and some of their priorities and things. So I don't know if that's exactly an incentive, but it was a different way of engaging.
Okay, fantastic. I'm mindful we've got about 8 minutes left, and there are more questions than we can ask. So I am going to make some executive decisions. I'm going to go to one that I'm interested in from Sarah Cork for Sue. How did you evaluate the actual rather than claimed behaviour change and awareness? What was the sample size and method for pre and post awareness / behaviour? And this is always something we find tricky in terms of claimed and actual behaviour. So have you got an answer for that, Sue? Per your question.
Well, we didn't evaluate the actual. It is a good question, and we have this conversation all the time around things like changes to physical activity behaviour, changes to eating behaviour, etc., etc. And I guess we decided that we would trust what people were telling us. Paul might have things to add to this.
Yeah, I was going to say
Paul's involved in the project, but no, we didn't. And I do know that when some of the survey data around physical activity, for example, is followed up with actual measures, people do tend to overestimate their physical activity-ness levels and potentially underestimate some of their sedentary behaviour. But no, we did take people at their word. When Paul might have some things to add to that, though. Sorry to.
No, it's good. I mean, I think in a way my answer to this echoes some of the questions we've talked about earlier about how to get meaningful community engagement. And I think we massively underestimate what good evaluation looks like. We're always trying to, and we don't plan it early enough. We don't think about what it actually means. So I think we do what we can, and actually all the projects that you've mentioned, like have had lots evaluation And so you use the best proxy measures you have with the resources we have. But I think my plea with my scientific hat on is kind of build that into your funding, build it into your partners, because so often what I see is people are just bunging 20 grand to an external agency to do something to evaluate a community-wide thing. And so it's the same principle basically, but you did an amazing job, and you did an amazing job at engaging different partners with both of the projects you mentioned.
Thank you. I think the other really tricky bit is what would the people that didn't engage tell us, isn't it? And that's a whole other conundrum and conversation, isn't it? What about those that didn't want to engage? But yeah, thank you.
Okay, Tiago, did you have anything to add on measurement and impact?
Yes, I think it goes back to the final point that I made about being brave, because like Paul said, I think delivering a project, delivering an intervention, a campaign, it's very different than evaluating it. And I completely understand why budgets tend to be allocated for doing the thing rather than understanding whether it worked. So part of the bravery that it was on my notes was those conversations need to happen. If you want to understand if something really works, why, how, for what groups, that takes time, that takes resources. Evaluating that needs to be embedded from the beginning of the project, but it's a completely different activity to creating and delivering the intervention.
Okay, I'm going to stick with you, Tiago. Question from, apologies if I pronounce this name wrong, Juiced Gollebeck. You mentioned creating a commit framework. Would it be the intention to return to this framework annually to see whether the underlying assumptions and inputs remain true in future years, as I'm guessing the communities also evolve and change over time? And obviously that question you may wish to defer bits of that to Sue, but do you want to address it first?
Yeah, absolutely. I think so. That's something that we've been talking about. So the part of the Gloucestershire work that we delivered that resulted in that framework to anticipate behaviours. Obviously, that was done and delivered within the context of the project, within the context of smoking. The way we've delivered it, it's got potential to be applied and applicable to other areas and to other populations. But again, that requires further resource and further thinking. So what you've suggested would be ideal. It would be great to go back, to continue to iterate, to add more data to it, to test, to compare, to refine. But the way it was created it's open to that, but it was very specific to the Gloucestershire project.
So did you want to add anything to that?
I think just to say, well, we found out yesterday that our pitch for some evaluation funding had turned down for evaluating apparently due to just the numbers of people that had pitched in for some NIHR funding, I think. But we will, as you mentioned, we've used the insights to set our evaluation criteria for the tender, and we will also be looking to collect insights from those people that engage with services, and from those community organisations that work with those people. We're talking about some cohorts that are very underrepresented in services currently, despite having high rates of smoking. So I think we will certainly be evaluating the service, but unfortunately not with quite such a level of sort of pizzazz as we hoped. We will be looking for other opportunities to gather some funding to evaluate, and the service isn't yet in place. It will be in place towards the end of the year, so we've got a little bit of time left.
Okay, I'm going to ask one final question, to Tiago, and then I'm going to ask a question of everyone, and then we'll wrap up. So Tiago, how did you recruit to the citizens panel? Were the smoking intervention groups adjusted for diversity, age and gender? Is the recruitment from hospitals? So a kind of recruitment question more broadly, how did you go about that? And if you can answer that in less than a minute, I'd be grateful.
Yes, very quickly. So two ways of doing that. Recruitment partners. So we've partnered with an organisation called Ethnic Opinions to support the recruitment for the citizens panel, but the recruitment was done so alongside that project, we were running a steering group with professionals from public health and from the North East London Cancer Alliance to understand where were the gaps, where were the health inequalities. So we've combined everything. But the key point to say is that recruiting to the level that we did, to the populations that we did, took months. And that is something that we all need to be aware. If you want to engage the certain groups, specific populations, that needs to take time.
Okay, fantastic. Thank you. There are a couple of questions that we didn't have time for you, Sue, around your structural resilience model. And I think perhaps if you can take a moment now to jot an answer back on the Q&A function, or we'll follow up with those individuals who've asked those questions. I want to finish by kind of asking a broad question of everyone, like, what's your hopes for the future about the way in which this area of work evolves within public health? Are you hopeful that people are going to embrace this? Are you seeing change? What needs to happen for that to really gather momentum? And can I start with you, Paul?
I don't have time to think. So I think what I will say is, I think in the early days of behavioral science, people hoped that our little behavioral science models would be a shortcut to answer to kind of solve these issues, and we were looking to behavioral science to do the work that we're actually talking about right now, so that we didn't have to do this work. I think what is really heartening about this webinar is that this is behavioral science. This is the very nature. So what behavioral science can do is make us better listeners. It can spur our curiosity, and I think what I'd like to, so I want to see more of this work, but I'd also like to see people bridging the gap between professional and personal experience of the issues that we're all dealing with. We are all affected by these things.
And Caroline?
Yeah, I would agree. I mean, I think for us in North East London, it's still early days, really. So we're kind of learning still. But I think this should just, like, the work that's being done should just be, it should be a normal part of what we do. It should be what we just are, is just sort of fundamental to our projects and anything that we're doing. I think we've learned quite a lot from our public health teams who've been doing this for some time, so they're quite on the ball with it. But yeah, and I agree about the professional leaching, sort of feeding into the workshops and the work we're doing as well, because actually, and especially for what we're doing with the cancer work, nearly everybody in my team has been affected either directly or indirectly by some cancer. So we've all got something that we bring to the table, and I think it makes us more human and makes us more approachable.
Yeah, agree. And then Sue?
Yeah, I certainly agree with those points. I'm also thinking about the big changes that are happening within the system at the moment. So with the NHS moving towards a more preventive, community, digital approach, and looking at neighbourhood models, and as well as local government reform, where certainly within a county council, we'll be going to sort of 1 or 2 unitaries over forthcoming months, and which will mean potentially that we're working more closely with some of our community partners from the same organisation. And I'd be really keen to think about how we make the best of some of those opportunities to be working more closely in terms of place-based working and really engaging, getting to know our communities through some of those kind of national drivers, I think.
Okay, and then in less than 30 seconds, Tiago.
2 very quick ones. Being open to good ideas, not being snobby about just good ideas just coming from public health, being open to arts, marketing, comms, that sort of thing. There's good stuff happening everywhere. And then the final one, and very quickly, is we talk a lot about building capacity within communities. I think we need to also build capacity in public health teams to understand what co-production means, to understand what an evaluation is. So when we think about building capacity, not just thinking about communities, but thinking about the whole system.
Fantastic, thank you. Okay, so we're out of time, need to wrap up. Thank you everyone on our panel for your contributions today. And thank you everyone for listening and asking excellent questions. If you've enjoyed the event, please do take a look at the 2 events I mentioned earlier. Our webinar next week on creating a society that values care, and our new bite-sized event on the science behind scarcity. Details are in the chat. Also do sign up to Clare Mail on the Claremont website or follow us on LinkedIn. We aim to send a Clare Mail every 1 or 2 months, and this is always the first place you'll hear about our events. And again, I think you'll find the details for that on the chat. If you've got any comments or feedback about today's event, please do email us at hello@claremont.org.uk. Okay, well, we hope to see you again soon. Goodbye for now.